Good evening. Shall I start, sir?
Yeah, please go ahead. Yes.
Good evening, everybody. Welcome to the second part of the lecture on surgical nutrition. Um, I'll go back to, I think I've already went forward. I think the main thing to just remind you of the important points of the last class is that nutritional survey is critical in almost all patients who get admitted in the Department of Surgery as far as we are concerned. And then patients who are going to stay for long with the larger operations for malignancies and more difficult conditions, you have to initially do a nutritional survey and then a complete nutritional assessment before deciding any nutritional support or therapy is required. Now, let me start this class by going through the aims of the nutritional support and therapy. So, the main thing is to meet the daily nutritional requirement, including the macro and micronutrients, electrolytes, and water. By doing so, you trying to attempt to reduce the catabolic phase. All patients who are sick, patients who are in intensive care, patients who are undergoing major surgery will and patients who are septic will have hypercatabolic state. So the previous thought process used to be chase the catabolism by increasing the calorie delivery, even sometimes up to 4,000, 4,500 kilocalories. But then very quickly they understood the fallacy of this approach, and then a more balanced, more pragmatic approach of obligatory under nutrition was brought in, which has actually made a huge difference in terms of patient recovery and response to sepsis and systemic inflammatory response syndrome. So, the purpose of nutrition is to reduce the catabolic phase of the post-operative and perioperative recovery, reduce the insulin resistance and sarcopenia. I think I have stressed this quite a lot in the last class, so I shall not do that again. Reduce glycogenolysis and gluconeogenesis, boost the immune system, promote tissue healing, promote and accelerate recovery from surgery and return to work and normalcy. So these are the aims of nutritional support stroke therapy. Coming to various forms of nutritional delivery, nutrition delivery has to be customized. There is a large Cochrane system review of 25 studies involving about 8,900 patients. They have studied 25 studies, out of which 17 studies have compared enteral nutrition versus parenteral nutrition. 6 studies have a combination of enteral nutrition versus enteral plus parenteral nutrition, and 2 studies are multi-arm. So they found that with any form of nutritional support, there is no difference in 30 or 90-day mortality, ICU stay, or ventilator-free days, or incidence of aspiration and pneumonia. So this only shows that there is no superiority in terms of enteral nutrition or parenteral nutrition or a combination thereof, but you have to customize your approach to nutrition in every patient and be pragmatic about how you deliver nutrition. Now, coming to enteral nutrition, there are various routes of delivery of enteral nutrition. Oral intake, if the patient is able to take orally, then encourage oral intake. This is one of the caveats of the enhanced recovery program. So uh, early nutritional intake about 2 hours after surgery is generally what is recommended in the ERAS protocol. So if the patient is unable to feed himself or herself, nasogastric tube, nasojejunal tube, and if the patient is unable, or if it is long term where nasogastric and nasojejunal tubes may have their own problems, you then resort to percutaneous endoscopic gastrostomy, percutaneous endoscopic jejunostomy, which is called PEG or PEG. And then also, if you're doing major abdominal surgery like esophageal surgery, gastric surgery, Whipple's resection, colectomies, and such like, you consciously think about the nutritional status of the patient preoperatively, having assessed them, and then place a surgical jejunostomy, or if you can do it laparoscopically, you can do a laparoscopic jejunostomy. So the purpose of this is to deliver 25 to 35 kilocalories of per kg per day. The carbohydrate is delivered at a rate of 4 grams per kg per day. Lipids 0.7 to 1.5 grams per kg per day, and amino acids 1 to 1.8 grams per kg per day, or if you are calculating in the form of nitrogen, zero point 0.5 to zero point 0.2 gram per kg per day. The importance is to start nutritional supplementation or therapy slowly, usually at a rate of 50% of the requirement, and gradually progress to full requirement depending on the stability of the patient, the condition of the patient, and tolerance of the patient. So, generally, what is recommended is you start with the enteral feed either in the form of oral intake or any of the tube feeds, and then you aspirate every 2 or 4 hours and see how much of residue is left and how much is being absorbed. And then depending on how depending on the status of the abdomen, if there is any distension, and if the patient is vomiting, for example, or if there is very high gastric aspirate or the tube aspirate, then obviously you have to go slowly, but start slowly and reach the full dose by 48 to 72 hours. That is the general recommendation. There are many types of enteral feeding regimes depending on the condition of the patient and the location of the patient and the indication of the enteral feeding and enteral supplementation. In the hospital, generally bolus feeding is what is practiced. 150 to 200 ml every 2 hours or so, and you can also, if the patient is on long term or medium term enteral feeding, cyclical intermittent feeding 8 to 16 hours, which is start around late evening and then go on through the night and then stop during the day, which allow the patients to be mobile and maybe even work, if that is what they do. And this is also tailored to the needs of the patient and the mobility and the general condition of the patient. Intermittent drip feeding is also practiced, and continuous feeding is generally practiced in patients who are bedridden, elderly, patients who have, for example, neuromuscular problems, difficulty in swallowing, whom, and usually this is practiced in medical patients and continuous feeding through the day. As I said, the type of feeding depends on the indication of nutritional supplementation or therapy and general condition of the patient and the duration of the support. Coming to the indications of enteral feeding, the dictum is use the gut whenever available, whenever possible. So this is the default mode of nutritional support or therapy. So this point should be very carefully understood by everybody. So if the gut is available, please use it. So that is the dictum. Which are the patients who need nutritional support? Patients who are malnourished or at risk of malnourishment. So this I have already discussed in the last class, the assessment of nutritional risk or nutritional status of the patient, and patients who come into the category of either already malnourished or at risk of malnourishment. Such patients need to be fed. Patients who are critically ill where oral intake may be not possible for a considerable period of time. Patients who have developed postoperative complications where enteral feeding is possible, but the patient may be very weak to tolerate it, and hence you may have to resort to tube feeding. patients who have intestinal fistulae and Crohn's disease and short bowel syndrome. The previously intestinal fistulae postoperative complications used to form a large part of the indication for parenteral or total parenteral nutrition. But advances, from especially from the hospital due in Paris, who started what is called as a chime feeding. They would collect the output from the fistula in a sterile manner and strain it and then mix it with feed and then refeed the patient the effluent that comes out from the fistula. So for this there are many caveats. One is that the gut should be working. Second, you should have the accurate knowledge of the anatomy of the patient, which means what is there before the fistula. Is it a single fistula, multiple fistula, and what is the length of the bowel beyond the fistula? Is the bowel healthy? Is there any evidence of obstruction or disease in that segment? Is it communicating with general peritoneal cavity or an abscess cavity? All of these things have to be ascertained, which means you do a CT enteroclysis or even fistula study through the fistula and then ascertain that the anatomy is okay for you to feed, and then you can insert a tube into the distal end of the fistula and feed the proximal output from the fistula. And you, in addition to this, you can add in semi-elemental or elemental diet feeds, which will give the patient nutrition. In addition, the bowel mucosal integrity and health will be maintained, and the bowel circumference and the bowel strength will also be maintained. So once the patient is then fit for surgery, when you take him up for or her up for re-operation, the bowel which is distal to the fistula is also healthy and the anastomosis is easier in such patients. And you can also reduce the dependence on parenteral nutrition. So this is the recent, it's not so recent, but what we used to call as fistuloclysis. So feeding the effluent from the fistula into the distal limb of the fistula, and that can completely obviate the need for parenteral nutrition or reduce the dependence on parenteral nutrition. So that is one thing. Other thing is there is also significant proof that Crohn's disease, because the cause of Crohn's disease is not clearly understood, and it is definitely an immunologic phenomena. Immune nutrition in patients with Crohn's disease, and also diversion of food or fecal matter to the affected segments seems to improve the disease severity, and also it can sometimes even heal the disease. So in Crohn's disease, either avoiding feeding the patient through the oral route or feeding immune nutrition through the either the fistula or orally seems to work in patients with Crohn's disease. And short bowel syndrome is another indication, but again, it is an anathema that you think short bowel syndrome patient should not be fed. But again, a proper anatomic study of the patient's remaining bowel and see whether there is any disease left in the segment and what is the length of the bowel available. Is it small intestine, large intestine? Is there ileocecal valve present? All of these will determine as to how much enteral feeding you can give to such patients. The other advantage of this route is that the more you feed these patients over a period of time, there is adaptability of the bowel, and the bowel will learn to absorb more and more. And sometimes, in addition to being on it to parenteral nutrition, you can slowly reduce the dependence on parenteral nutrition in patients with short bowel syndrome. So that is another indication for feeding enterally. So coming to contraindications, hemodynamic instability is one contraindication. Patients who are in ICU, who are on multiple inotropic support, septic. The reason for this is that, as you know, whenever there is hemodynamic instability, when there is hypotension, tachycardia, the splanchnic circulation suffers a lot. That means there is reduction in blood supply to the intestines and liver also. In addition, these patients may be on several inotropes, and all the inotropes cause reduction in splanchnic blood flow again. So, apart from vasopressin and maybe to some extent, if you are giving higher doses of dopamine, which usually is not done nowadays, when it works on the beta adrenergic receptors, it seems to increase the blood flow. Otherwise, it also reduces the blood flow. So most of the vasopressors will reduce the splanchnic blood flow. So hence, there is no advantage or sense in giving enteral feeding in that situation. Active GIBD is self-explanatory. Patients with intestinal obstruction, pseudo obstruction, Ogilvie syndrome, so paralytic ileus, you can't feed them till the bowel starts working. Malabsorption syndrome patients who have various medical conditions of malabsorption, such patients enteral feeding in its a relative contraindication. And GI fistula, as I have already explained, is a relative contraindication. If you can map the anatomy of these patients, you can feed them distally. Short bowel syndrome is if, for example, the length of the small intestine is less than 80 centimeters, if there is absence of ileocecal valve and significant portion of colon, and when there is high output fistula, you have to moderate the dependence on enteral feeding, and you may have to give them parenteral feeding, but you can also give them um, enteral feeding in the form of semi-elemental or elemental diet. And as I said earlier, there is definitely significant adaptation of the bowel, which will gradually reduce the dependence on TPN, if not completely. So this is just a picture of the peg insertion, and PEG is one of the most common forms of long-term enteral feeding that we use. We can also use PEG in patients where it is feasible. Now, coming to the advantages of enteral feeding, first thing is it's very safe, it is effective, it is physiological, it reduces the risk of infection by several methods. The main method being maintenance of the gut blood flow and gut integrity, the mucosal integrity. So, because by doing this, by augmenting the gut blood flow and mucosal um, maintenance of the mucosal integrity, the gut barrier function is maintained, and hence translocation of bacteria, which is one of the main sources of sepsis, is avoided. So that is how it reduces the risk of infection. And obviously, the parenteral nutrition, depending on the lines, one of the major risk factors will be line sepsis. So that risk is also avoided. Obviously, there is reduction in cost, and as I said, prevention of gut atrophy and preservation of the gut barrier function. So these are the advantages of enteral feeding. Complications of enteral feeding, again, I think we should all be very wary of thinking that enteral feeding is extremely safe, which it is, but you have to be aware of all the possible complications. Complications are related to both the feed itself and the tube. I have seen all the complications that can happen through the malposition, dislodgement, breakage of the tube, leakage around the tube, erosion of the tube into other organs or into the peritoneal cavity. I had to operate on a patient who was being fed for the last 30 days without realizing that they are feeding into the general peritoneal cavity. There was a huge hole around the percutaneous endoscopic gastrostomy tube, and all the feed was in the peritoneal cavity and formed a big cake. And finally, the patient presented with peritonitis, and we had a great task trying to get rid of the all the caked up material. So it is not without its kind. So there should be checks and balances when you feed these patients. You have to be aware of the possible complications, and then the tube can get obstructed. There can be infection around the tube where the tube enters the abdominal cavity. And then the complications relating to feed are infection, diarrhea because of the malabsorption, and refeeding syndrome. I will come to the refeeding syndrome in general because refeeding syndrome, whether it is post enteral feeding or post parental feeding, is kind of similar. So I will be addressing that in the later part of the talk. Coming to the types of enteral feeding, there is a significant move towards using natural available material for enteral feeding, that is in the form of milk or fruit juices and fiber and whatever food that is cooked at home, which can be blenderized and then used through the tube. And this seems to make a lot of sense, and it is easily available at home and at no extra cost, and because it is prepared at home, it is also quite safe. So there is a trend towards giving natural blenderized food. Then there are polymeric feeds, which can be classified into elemental and semi elemental. Then there are specialized feeds, modular feeds. Generally, the content of the enteral feeding should be carbohydrates 30 to 60%, protein 10 to 25%, lipid 10 to 45%, depending on the needs of the patient and whether the patient is obese or the patient has other diseases like diabetes, renal failure, liver dysfunction, all of these things. So you have to take into consideration all of this and customize the enteral feeding. But this is the general ballpark figure for the three essential elements, which is carbohydrate, protein, and lipid. The general thinking is that the proteins, the calorie, though it gives you 4 kilocalories per kg per gram of protein, generally protein, what we call as a non-protein calorie intake, should be what should be considered, because protein, especially in patients who are sick, patients who are in intensive care, patients who are recovering from major surgeries, will need the protein for the healing process, for the for the healing of the anastomosis and general improvement of the body. So you do not countenance the calorie that come from the proteins in the daily calorie, so feeding that you give. And generally, most of the enteral feeds give you 1 to 2 kilocalories per ml. So, depending on the needs of the patient, for example, if there is patients who have cardiac illness, patients who have renal failure, whose fluid content, fluid restriction to 1 to 1.5 liters are there, in such patients, you can give them 1.5 to 2 kilocalories per ml, so that you can still deliver the same nutritional requirement of the patient at a lesser fluid volume. So that is how you have to customize the feeding. So what are the micronutrients and electrolytes that are there in the enteral feeding? So you have to have, I have just listed out everything: thiamine, riboflavin, folic acid, ascorbic acid, vitamin C, pantothenic acid, niacin, pyridoxine, B12, biotin, and all the fat soluble vitamins: iron, copper, zinc, fluoride, molybdenum, manganese, selenium, iodine, chromium. So the importance is they have conducted a huge study of all the available enteral feeds in the market, and fortunately, what they have shown is that what is called as the daily reference values (DRVs), and majority of the enteral feed supplements or the enteral feed formulas that we have do meet the daily reference values of all these trace elements as well. So it is good that they have taken the consideration of the requirement of the micronutrients and added them accordingly. Then coming to sodium, we need 1 to 1.5 millimoles per kg per day. Potassium 1 millimole per kg per day, and magnesium is zero point 0.8 to 1.5. Phosphorus is zero point 0.8 to 1.45. So these are all the daily reference values. So you have to feed the patient accordingly. That is the three macronutrients, the micronutrients, electrolytes, and the fluid. So all of this will constitute your ideal enteral feed. So what is this semi-elemental diet? It is partially hydrolyzed. That means the three macronutrients are partially hydrolyzed so that the patient, if for example you are feeding them distally and if there is the gastric and duodenal juices are not mixing with the food, then because they are partially hydrolyzed, they are absorbed distally, so that is why they are called semi-elemental. And if the gut is a lot of gut is not in action, then you can give them elemental diet, which will fully hydrolyze, which means that the body will just absorb them in their very elemental, very basic form. So that is the advantage in patients who have where the gut is, for example, not in contact with the digestive juices. So you give them elemental diet. So the example for semi-elemental is resource protein, ensure, fesubin, pentasure. And for the elemental ones are the Peptamen, Tabi Pro, HIP, Nutrimix, and things like that. These are all what is available in the market. And you have disease specific enteral feeds like those resource diabetic, for diabetes patients who have ARDS, you have formulas for patients with ARDS, patients who have renal disease, patients with gut and liver failure. You have separate, feeds. And so hence the enteral feed has to be customized to the age of the patient, the disease status, the comorbidities, the GI functional status, the fluid status of the patient, is there any need for fluid restriction, and also allergies. So if there are allergies, you have to take into consideration those things as well. So this is about enteral nutrition. So I hope I have covered most of it. Now I will stop and ask for questions, comments, and clarifications. Questions from students first, or any points that you want to clarify, or any mistakes you think there may be.
Hello, sir.
Ah,
Sir, is there any benefit compared to giving bolus or continuous feeds throughout the day? Because I have seen that they are saying continuous feeds are beneficial.
no, I think as I said, these feeds have to be customized, and depending on the patient, whether the patient is bedridden, patient is mobile, patient is sick, all of this. If the patient is bedridden and mobile, it is better to give them continuous feeds because they're not going anywhere. So you might as well, give them continuously, so the rate of infusion can be titrated and monitored. On the other hand, if the patient is nutritionally deficient but strong, fairly mobile, it may be beneficial to give them bolus feeds or overnight infusions, and then during the day they are able to be free and to do their work or whatever. So many of them that can be done. So it has to be customized. I don't think there is any advantage of one form of delivery to another form of delivery.
Looking on the position of the tube, sir, when it is in nasogastric and when it is in nasojejunal, something like that.
Ah, yeah.
So even then, if you are giving bulk, so I mean, at a time, does it cause any
Bolus, yeah.
bolus?
Yeah,
Does it cause any problems?
I don't think it causes any problems. I think it is, as I said, it has to be, generally, all these tubes are placed according to the needs of the patient. If, for example, you are, long term, you have to place either a feeding jejunostomy or a feeding gastrostomy. If it is short term, then you use nasogastric or nasojejunal tubes. And then depending on the needs of the patient and the patient, how the patient tolerates the feeds, you give them boluses. And then you can even give where and then because it is more physiological, because nobody eats during the night, you can give them feed during the day and give them rest at night. So all of these things can be done.
Yes.
Lakshman sir,
To
any comments so far, sir?
do percutaneous endoscopy jejunostomy,
Ah,
how do they localize the jejunum?
what they do is I think we one of our papers was that basically they use endosono, and they inject dye and into the duodenum, and that it comes into the jejunum, and they detect that by the endosono, and then they put a needle into the jejunum, and then they do the percutaneous endoscopic jejunostomy using a guide wire. Lakshman sir, any
Yeah, I
comments?
think, comprehensive, I think very detailed and very correctly said. My only question is, are these, I really don't know, these elemental diets available in our country?
Yes, I think some of them are maybe available, but I am not sure.
Yeah, I
Many
sort of,
semi-elementals are available, sir.
okay.
Elemental, I am not so sure.
Yeah.
Now, moving on to parenteral nutrition. It was first started by Dutrick. I am not sure when it was, but I think it is somewhere in the 1940s or 1950s.
67 or something like
Oh,
that.
okay,
Yeah.
1967.
I have met the gentleman in the US. Yeah. Go ahead. Yeah.
Okay. So, that again, delivery of the carbohydrates, proteins, lipids, vitamins, electrolytes, trace elements, and water through the parenteral route. And the important thing is there is no urgency about starting or parenteral nutrition or total parenteral nutrition. Proper nutritional assessment, indication for the nutritional support or therapy has to be ascertained, and the duration of parenteral nutrition also has to be ascertained before you start the parenteral nutrition. So there is no urgency about it, and it can be as an adjunct to enteral nutrition when it is called parenteral nutrition, or if it is the sole nutritional source or delivery, then it is called total parenteral nutrition. So, what are the indications for parenteral nutrition? Surgical complications. I put it first in the list because we are as surgeons. This is where is the commonest indication for TPN. Patients who are critically ill, patients who have intestinal failure, short bowel syndrome, obstruction and pseudo obstruction, radiation enteritis, high output fistula, inaccessible GIT, and mesenteric ischemia. I think majority of the indications are self-explanatory. Uh, a point about radiation enteritis, with the advent of image-guided radiotherapy and intensity modulated radiotherapy, and pre-operative or intraoperative radiotherapy, the gut is less likely damaged in these radiotherapeutic measures. So the incidence of radiation enteritis is not gone completely, but it is much less. We see that much less compared to before. Before it used to be only cobalt radiotherapy, which would cause significant damage to the bowel. With the advent of the newer modalities, I think the incidence of radiation enteritis is less, but it is one of the indications for parenteral nutrition. So there are three types of parenteral nutrition based on the duration. One is the acute, that is what we usually follow in patients in the immediate post-operative or peri-operative period, or even pre-operative if indicated. Prolonged nutrition is in situations where patients who have maybe intestinal fistula, or you want to rest the bowel before you take them up for surgery again, and bowel is not in continuity. In such situations, it may be prolonged for a few months. And then there are patients who have severe mesenteric ischemia, multiple resections in Crohn's disease, and things like that, where they will be on home parenteral nutrition, which is called chronic. So the initiation of parenteral nutrition in a patient who was previously well nourished should be at least after 7 days after the, either let us say in the post-operative period. You can give a grace of up to 7 days if the patient was previously well nourished, and then if you think the patient is now not getting his required nutritional needs in the through the oral route, then you should consider TPN. And in patients who are already malnourished according to your either the survey or assessment, then you should start the nutritional supplement TPN 3 to 6 days of the illness. See, the other important thing is the EPANIC trial, which looked at the risk benefit ratio of TPN. Important thing is, if you are thinking of giving them TPN for a period of 3 to 5 days, don't bother, because I think the risks of TPN is much higher, but the benefits you accrue are much less. Hence, if you are going to give them feed TPN for a parental nutrition or TPN for a period of 7 days or more, then it is definitely beneficial. So hence, there was a very good study from even from Swope Hospital where I was working, that the surgical wards and the gastrointestinal medical gastroenterology wards were next door to the intestinal failure unit, and we compared the practices in the our unit in the new intestinal failure unit to the surgical and medical gastroenterology wards, and it was startling to know that many of these patients were having TPN for a period of 2 days, 3 days. So what happens is, you have to assess if the patient is actually going to need the parental nutritional support, and how long is he likely to be needing it. So this assessment has to be made carefully before you make the decision to feed them. So there is the concept of nutritional support team. This applies to both enteral and parental nutrition. The surgeon, obviously, physician, that is usually a medical gastroenterologist, dietitian, pharmacist, and nursing staff. All of these are part of the team, and every patients who are needing enteral or parental nutritional support, there should be a meeting on a regular basis to assess the progress of the patient, the needs of the patient, the calorific and nutritional other nutritional needs. All of these things have to be assessed, and also looking at the delivery in terms of the access, whether it is the tube feeding, or is it central venous or peripheral venous access. All of these things have to be assessed on a regular basis, so that the patient does not come to any harm by your nutritional support. So the regular monitoring of the general condition of the patient, fluid and electrolyte balance, regular glycemic control and electrolyte balance, and whether the patient is septic, and that again, that has to be assessed, and the basal metabolic rate. If you have the facility, you can do the metabolic rate with the metabolic card. Otherwise, you can assess that by indirect methods. Hyperosmolar solution reading to rapid ionic shifts. So this kind of hyperosmolar solutions cannot be given through the periphery. So you have to use a central line. So that is called a central venous access. And again, the decision whether the patient has to be fed centrally or peripherally has to be made by the nutrition team based on the duration of the nutritional support, the calorific and the other requirements of the patient. Coming to the complications of TPN can be feed related or access related. The feed related is hyperglycemia, that is the most common complication, and hypoglycemia consequently when the TPN is stopped. So that has to be very carefully monitored. Previously they used to have a very rigid control of sugar at 115 milligram percent, which is now been upregulated to 180 milligram percent. So there is no need to be extremely rigid about sugar levels. There was also, as I previously quoted, a study from Netherlands in patients mainly going through cardiac operations, where they monitored the sugar levels at second per every second, and the insulin infusion used to be given to them along with the TPN, to monitor, to have the blood sugars very rigidly in the given level. That was intended to reduce the sepsis and also dependence on the ventilator and ICU stay. But they showed that there was no improvement in patients who had this rigid glycemic control as opposed to patients who had a reasonable glycemic control, and hence that was given up. So the current understanding is that you maintain the sugar levels around 180 milligram percent, which is sufficient, and hyperglycemia has to be one of the most important things. So patients who are on TPN, most of the TPN bags will have insulin in them. Otherwise, you have to monitor sugars, especially when you start the TPN. The first 48 to 72 hours, you have to be extremely careful and monitor the blood sugar levels and give them insulin accordingly. The other complication is hypertriglyceridemia, and this can affect a lot of organs. It can cause liver dysfunction, cardiac dysfunction, cardiac failure, congestive heart failure, pulmonary edema, and things like that, and even maybe precipitate an attack of pancreatitis. So you have to be careful about hypertriglyceridemia. Electrolyte imbalances, as you know, it's not just part of the refeeding syndrome, it can just or solutions, they cause significant fluid shifts from extracellular and intracellular compartments, movement of potassium and sodium and other ions along with the fluid. So hence there can be significant variation in these levels. So these need to be monitored. Liver dysfunction, as I said, if the patient, a TPN related liver dysfunction is a very well described classical feature, and also because of the lack of enteral stimulation, because that is another important, the portal venous flow will be reduced in patients who are not being enterally fed. That will also lead to the liver dysfunction. So all of this will cause steatosis of the liver, and over a period of time, again, gallstones is another complication. Cystitis, gallstone formation, early gallstone formation, and then liver dysfunction leading to liver failure also is well described. So hence, especially in patients who are on long term TPN. And then if the fluid status of the patient is not well monitored, see, when I come to the peripheral TPN, I'll describe this again. But what happens is peripheral TPN, the osmolality of the fluids is much less. So you'll have to give them higher volumes of fluid. So patients who have renal failure, cardiac failure, it may be difficult to do that. So that is why pulmonary edema and heart failure can happen. And then refeeding syndrome is also well described. Now coming to the complications of parenteral nutrition that is related to the access. So the most important complication is line sepsis. So what is the definition of line sepsis? The line sepsis is systemic blood-borne infection in the patients, directly related to the catheter that is inserted for the purpose of parenteral nutrition. So that is the definition. How do you quantify this? The patient should have fever and systemic inflammatory response syndrome. In addition, the cultures have to be done through the peripheral blood, and also cultures to be taken through the catheter, and the organisms that you grow should be similar, and also you quantify what is called as colony forming units through the blood culture that you take through the line. So if all of these prerequisites are met, then you classify this as central venous catheter related sepsis, and this is an extremely serious condition. If it goes unrecognized, obviously it can lead to one systemic sepsis and seedling of infection in the liver, brain, and also infective endocarditis, which can be lethal, and infective myocarditis also. So hence, catheter related sepsis has to be taken very seriously. And how do you avoid it? See, the most important thing is the line that is inserted for the purpose of TPN has to be guarded extremely carefully, and the access to that should be done by trained personnel using absolutely sterile aseptic precautions. The line should be used for feeding and feeding alone. Don't use the line to take blood out of it, to give antibiotics and other medication. You use other lines for that, but don't use the TPN line for accessing for other purposes. So, and when you connect the TPN, it should be done with a very sterile manner so that you reduce the. Again, this phenomenon was studied very clearly in our intestinal failure unit, where the nurses adapted these very strict aseptic precautions as compared to the teaching hospital, which was next door, where the incidence of line sepsis was anywhere between 16 and 25%, as opposed to 0% in the intestinal failure unit. So that is why it is extremely important, even though you are in a university teaching hospitals, still line sepsis is a significant problem if you don't follow the strict aseptic precautions. So line sepsis is an extremely so dangerous and sometimes even lethal complication, so which has to be addressed very carefully. And when you suspect line sepsis, you should stop. It's not necessary, especially if you have already put a Hickman or a Broviac line. It doesn't mean that you have to remove the line immediately. Line can be salvaged. There are line salvage procedures. You have to stop feeding through the line, or if you have to feed through the line, you only feed lipids. Don't feed sugar through that, that is glucose or carbohydrates. Just feed lipids through the line. And then IV antibiotics have to be, the line has to be flushed with IV antibiotics, and systemic IV antibiotics has to be given as well. And with that you can salvage about 75 to 80 85% of the lines. So line sepsis has to be very carefully avoided as much as possible and treated appropriately. Other thing is major vein thrombosis, because it's the hyperosmolar hygroscopic solutions. If the line is not placed in the appropriate place, if it is in more peripheral area, then the line can cause thrombosis, which can then the thrombosis can spread to all the major veins in the mediastinum and deny intravenous access to these patients. So it is a very major problem. We have had to put lines directly by the cardiac surgeons doing a cardiac entry into directly into the heart. We have had to do that 2 or 3 patients because all their veins were thrombosed. So it is not an uncommon problem. It has to be avoided by careful as I said, careful monitoring and maintenance of the line. Line blockage again is a common problem, because again we are using very hyperosmolar solutions, which if the rate of the flow is not carefully monitored, when there is slow flow, these things can the particulate matter can aggregate, and then that can cause line blockage. Line can be displaced and malpositioned. And thrombophlebitis is more common problem in patients with peripheral lines, either dedicated peripheral lines or the PIC lines. So that is much more common as opposed to the central lines. So just a brief note on the refeeding syndrome. So what is refeeding syndrome? It is a potentially fatal metabolic complication. There are significant fluid and electrolyte disturbances. See, the patients who are very severely malnourished, so that is why I've quoted that in the below. Patients with a low BMI of less than 18.5, patients who have had significant weight loss of over 5 kgs in the last month, or 10 kgs over the last 3 to 6 months. Patients who had a low oral intake of less than 50 to 70% of their daily requirement. Patients who have quantified muscle and fat loss, and patients who, when you first see them, have abnormal electrolytes, and patients who are alcoholic, patients who have eating disorder, and patients who have malignancies. All of these patients who are nutritionally either malnourished or at risk of malnourishment, such patients are more prone to developing refeeding syndrome. So hence, what happens is mainly phosphorus, potassium, magnesium, and thiamine deficiencies will happen. The main effects of this is significant fluid shifts, which causes water retention, heart failure, and pulmonary edema, and neuromuscular paralysis, sometimes leading to even death. So you have to be careful about refeeding syndrome. So how do you avoid this? Is one, first do proper nutritional assessment of these patients, and check their electrolytes and everything, and start feeding slowly and gradually build up this with these patients. Do not maybe take a week or so to start with 20 to 25% of their daily requirement, gradually progress to 50, and then up to speed of full requirements over a period of 1 week or so. So that can help to avoid refeeding syndrome. Okay. Now coming to peripheral TPN. So the peripheral TPN, the usual osmolality of the peripheral feeds is between 700 to 900 milliosmoles per liter. Hence, you need higher volume. It will almost always will have less calories, less proteins, and less carbohydrates. The proteins will be less than 4% of the total requirement, and carbohydrates less than 10%. There will be more lipids in the peripheral TPN. Other micronutrients you can add as much as you really need, but you cannot give them higher proteins and higher carbohydrates. And so hence it may be difficult in patients who have heart failure, renal failure, liver failure, because there is a significant fluid restriction in these patients. The access through for peripheral TPN will be through PICC lines, which is usually through the cephalic or the basilic vein. And there are now what is called as midline catheters that go up to the axillary vein. It doesn't go into the total central, to the jugular or the subclavian or the vena cava. They go up to the axillary veins, and they can be used for a period of 2 to 4 weeks for nutritional support. And then you can also have dedicated cannulas in patients who may need nutritional support for a period of week or so. These cannulas have to be dedicated for feeding alone. They have to be inserted under sterile circumstances and maintained the utmost asepsis, and used only for feeding and not used for other purposes. And they should be recycled every 4 days or 5 days, depending on the presence of thrombophlebitis, and or if the vein is getting clotted because of the hygroscopic solution that runs through it. And hence you have to recycle the peripheral cannulas, but again used only for a short period of time. And as I said, thrombophlebitis, in addition to all the line related complications which I've already described in the peripheral TPN. Coming to central TPN, the central TPN is delivered by Hickman line, Roviac line, Groshong or Pons. These are all different makes, and you can also have implanted ports. These lines are either non-tunneled or tunneled, and when they are tunneled, there is a there is a uh, ball of tissue, a ball of which will anchor the line to the subcutaneous tissue. I think it is made of Teflon, and hence the line is secure, and that will give you the that sleeve of Teflon will give you the indication where the line is, and hence you can monitor it. And it is usually placed through either a subclavian vein or jugular vein, or even cephalic or the basilic vein, using a cut down method. Or if you can also use the standard Seldinger technique also to insert these lines. It has to be done in the operating theater. You can't do this in the ward and things like that, because it has to be done under absolute strict aseptic precautions. And it has to be used only by dedicated trained personnel. And surprisingly, even patients can be trained as to how to use the line, and many of the patients who are on home parental nutrition do so very well, and the sepsis in those people are not significantly more than the what we see in the wards. So they, if you can train the people properly, they can maintain the lines well. There should be dedicated protocol for placement of the line, usage of the line, and suspected line related complications to recognize the problems early and manage them. So this is the the Hickman lines. This is the the sleeve of thing, the Teflon that I was telling you. So this can be placed either by the percutaneous Seldinger technique, or using the, this is the cephalic vein, the basilic vein. You can go through any of that. The important thing is the line should reach the interface between the superior vena cava and the right atrium, because at that point, the because the line is reached absolutely very close to the heart, the hygroscopic solution will not damage the vessel wall, and hence the thrombotic complications of these patients will be much less. So this is the Broviac line, and it is placed through this and into the interface between the superior vena cava and the right atrium. In the rarely you can also use the femoral vein when the upper limb veins are all destroyed or thrombosed, and much less preferred. The infection rates are much higher because it goes through the groin. So, and then it usually stays in the inferior vena cava because majority of the lines that are there are not long enough to reach the this one superior vena cava or the right atrial junction. Hence, they stay in the inferior vena cava through the femoral vein. Much less preferred, but sometimes you can't help it, you have to use it. Again, TPN can be continuous or cyclic. In the initial phase, it has to be continuous because of the rapid fluid shifts and ionic shift that happen because of the hyperosmolar solution. Once the patient is stabilized on that, especially patients who are on long-term home parental nutrition, you can use a cyclical schedule where the patients are fed overnight and during the day they are free to do their work. Many of them are young patients who have had mesenteric ischemia or short bowel syndrome. They will be working professionals, so it will afford them the opportunity and flexibility to work during the day and have the feeds during the night. So that is the advantage of the cyclical schedule. And you can also use inline filters which are available now to avoid particulate and precipitate matters because that can cause blockage of the line over a period of time. There are two different methods, which is a hospital based pharmacy based compounding solution or commercially available TPN, which is either single chamber or three chamber preparation. So previously they used to use what is called a two-in-one preparation, where the protein and carbohydrates were in one bag, and then the lipid used to be infused separately. And nowadays we have all in one single bag system where even the electrolytes, micronutrients are all added. Sometimes they come in three different chambers, and then there are temporary kind of barriers between the three, and it can be broken open into to convert that into a single chamber solution. And the shelf life of these is up to 24 months. So it's not, that is 2 years. So it is not so, but only thing is it has to be stored properly, especially to avoid photo, and oxygen related degradation. So they have to be stored appropriately. Even the pH and the electrolyte content has to be, if you are giving, for example, the hospital pharmacy compounded TPN can be, customized every day depending on the electrolytes and the need of the patient and everything. But the commercially available ones are all generally will have standard amounts of all the, the electrolytes and nutrients. And generally it is advised that the, the electrolyte content is, on the lower side, because higher electrolyte content will cause precipitation and also particulation, especially calcium and other trace elements can cause particulation. So hence you maintain the electrolytes at a reasonable level. If additional electrolytes are required depending on the patient's, electrolyte levels and condition, it can be given through IV infusion. So hence TPN will meet the usual requirements, but any additional requirements can be given as supplementation. As I said again, 25 to 35 kilocalories of kg per day, and this is the, what you call as obligatory under nutrition. Previously they used to go to 50 to 85 kilocalories, which used to be very high. So 25 in a patient who is 70 kilograms is only what 1800, and up to 2000 to 2300 to 400. So that is the general calorie that you give, and the optimum non-protein calorie nitrogen ratio. This is very important. So that means usually you don't use nitrogen or the protein as a source of calories because they give you 4 kilocalories per gram of it. Generally is utilized for the tissue, repair and, healing process. And hence, the optimum ratio is 70 to 100. In obese patients, it can be reduced to as low as 50 to 1, 50 to 1 ratio between a gram of nitrogen to the kilocalories ratio. As I said, again, 40 to 60% of this daily requirement is given through carbohydrates, 30 to 40% through lipid, and 10 to 20% with proteins. Commercially available, feeds will have essential amino acid, branch chain amino acids. Various sources of lipids can be used in specific indications. For example, the lipid that comes out of soybean oil and egg yolk is rich in polyunsaturated fatty acids and phytosterols. Coconut oil is rich in medium chain triglycerides, which are very healthy. Olive oil is lower in essential fatty acids. So, in patients who need less of fat, you can use olive oil based feed. Fish oil is higher in the omega 3 fatty acids. And so, the many of them are available intradipate, lipofundin, omega 1. Omega 1 is mainly rich in the omega fatty acids, and SMOF lipid is also available, which is also very it is to a certain extent part of the immunonutrition profile. So I think we have come to 10 o'clock. I think the immunonutrition is a important topic, and I don't think I can run through it in 5 minutes or so. So I would ask the permission of Dr. Lakshman to maybe postpone the immunonutrition to the next class.
Sure, Ravi, please. I think it is important that we learn about it. Yeah, I agree.
And because it will take about 10-15 minutes, I don't think it is. I think it's a very vast topic. I have cut down on what I
very
could
extensive
detail.
about difficult to concentrate. Next class
Okay, right.
And I think even the parental and enteral nutrition, I think I've kept it to the basic minimum because there is so much of details in each of these feeds and everything. And for example, there are specific feeds in patients with pancreatitis and all these things, which we can talk about. But I think I've given the sort of basic sort of rule of the thumb in initiation of enteral and parental feeding. Now I'll ask the students for
Let
questions.
them also read and come so at some 10-15 minutes they can discuss whatever you are this thing.
Yeah, so we'll talk about immunonutrition in the next class. Students, questions, clarifications, comments, please.
This refeed syndrome, if you abruptly stop total nutrition,
Illa. If you start feeding
Start.
patients who are very severely malnourished.
That's what, if you start feeding, abruptly stopping the TPN.
Abruptly stopping feeds, the main problem will be severe hypoglycemia.
No. You abruptly stop TPN and start oral feeds, is it?
No.
Illa. Patients who are very malnourished, you start them on TPN or enteral feeding. You should not start, the full PET. For example, 35 calories. What you
Gradually
do,
increase.
give them 1,000 ml of feed slowly, at a rate of 20 to 30 ml per hour, that kind of thing. Gradually build up to over a week to the full requirement, which will be, for example, 100 ml per hour will be about 2 to 2.5 liters.
Okay.
So whether it is enteral or parenteral, in patients who are malnourished, as their the BMI is less than 18, patients who have lost 10 to 15% of their body weight over the last 3 months, or even more over the last 6 months, patients who have alcoholic or who have feeding eating disorders, patients with cancer and such like, you have to be extremely careful and start the feeding slowly and build up gradually to avoid refeeding syndrome. And even in patients whom you stop, you don't stop it abruptly, you have to taper it, so that especially TPN, you have to taper it, otherwise they will go into initial hyperglycemia and then later hypoglycemia. Students, questions, comments? Has it been useful at all, or is it
Yes,
Greek
sir.
and Latin?
No, sir, very useful in detail everything, what all we should know, and It was very nice, sir. Very good class.
Excellent talk.
Yes, sir.
Lakshman sir, your
Yeah.
comments.
Well, very nicely done, comprehensive. I think,
Simplified.
yeah, everything that has to be said has been said. Congratulations. I think it was a very good class.
Thank you. I think if there are no further questions or comments, we'll go to the
I'll-
next immune nutrition next time. And good night, everybody. Thanks for attending the class.
Good night. Good night.
Good night.